Hi, I'm Rebecca Scher. I'd like to present my study entitled Family Stability as a Predictor of Treatment Outcomes in HIV-Infected Adolescents. I'll first give some background about this population before moving on to the study itself. Adherence to art is worse during adolescence than during any other period of life, and adolescents have worse virological and immunological outcomes than adults or children. In South Africa, the rollout of 2004 has meant that our children have spent up to 9 years on art. As a result, our first generation of vertically infected children has survived into adolescence. According to UNICEF, there were 292,000 HIV-infected adolescents in South Africa in 2009, the largest population worldwide. However, these children face multiple challenges. Orphanhood in particular is extremely common, as the rollout came too late for many parents. The extended family has largely borne the brunt of this via informal fostering. Within this setup, anecdotal evidence suggests frequent household disruptions and multiple consecutive caregivers. What this means for treatment outcomes is unclear. Orphanhood has been extensively studied, and while double orphans are at higher risk of non-adherence, in general, orphans tend not to do worse on art. This has largely been attributed to the shielding effect of the extended family. In addition, the effect of the identity of the primary caregiver has been investigated, but the data does not clearly show where the benefit lies. However, the effect of multiple consecutive caregivers is unknown, although it is worth bearing in mind that fostering was common in sub-Saharan Africa prior to the AIDS epidemic too. Onto our study, we aim to determine whether there is a correlation between number of consecutive caregivers since start of art and the identity of the current caregiver, and viral load as well as ART regimen. In order to do this, we carried out a retrospective review of medical records in the Groote Schuur Hospital Adolescent HIV Clinic, one of the longest-standing adolescent clinics in South Africa, where some patients have been receiving treatment since 2002. We enrolled 203 subjects aged 10 to 19 years, all vertically infected with HIV and on art for greater than 1 year. Our primary outcomes were viral load, greater than or less than 40, and art regimen, first, second, or third line. These were analyzed in relation to number of consecutive caregivers since start of art, identity of the current caregiver, and orphan status. Looking at results, 54% of our subjects were male, reflecting a very different demographic to horizontally infected teens, who are predominantly female. Orphanhood as a whole stood at 51%, with 21% being double orphans. Half were on their first caregiver since start of art, another quarter on their second, and the remaining quarter of subjects had had 3 or more caregivers since commencing art. 1/3 of subjects was currently cared for by their mothers, followed by aunts, grandmothers, children's homes, foster homes, and other family. In terms of primary outcomes, a full third of patients were unsuppressed at last viral load, indicating in most cases a need for improved adherence. 52% were on a first-line regimen, 45% on a second, and 3% were on interim or holding regimens, awaiting third line. Data analysis revealed that having 3 or more caregivers was associated with a detectable viral load in males, but not in females. We found no association between number of consecutive caregivers and art regimen. Having an aunt as current caregiver was strongly associated with a detectable viral load, while staying in a foster home was associated with being on a first-line regimen. No other significant associations were found with the type of caregiver. When we looked at orphanhood in itself, we found, in keeping with other studies, that there was no association with viral load or art regimen. Unsurprisingly, however, there was a strong association with higher number of caregivers since start of art. Now, many of our results were limited by our relatively small sample size, so it's difficult to derive a clear pattern from them. However, what does emerge is that there are complex factors within the family that impact on treatment outcomes during adolescence. We recommend support for interventions that assist the struggling extended family to care for HIV-infected adolescents on a long-term basis. This unique population, both the first to survive into adolescence, and although optimistic, the last to have to do it without a biological parent, is uniquely vulnerable. There is a need for further study to clarify the role of family factors in order to support these adolescents towards a safe transition into a lifetime of adult care. Thank you very much.